Live now.
Good afternoon and welcome to the 12th and the last session of the BMJ India Webinar Series 2022. I am Sheetal Mattu Kaushik from BMJ India Marketing Team. BMJ is a global healthcare knowledge provider with a vision for a healthier world. BMJ supports healthcare providers around the world, from individual clinicians to major institutions, with evidence-based tools and resources to help healthcare professionals improve the quality of healthcare delivery. This program is an educational initiative by BMJ India, started in 2022, with the aim to bridge the knowledge gaps in different clinical areas and get your clinical questions answered by the expert speakers. Throughout these webinar series, we've discussed new and relevant topics each month, which have been delivered by different senior clinical experts from India who have shared their latest updates and practical tips for managing patients in primary care. We hope these series of webinars have created a positive impact on your clinical practice. We are also thankful to Tata 1mg Labs, who is our title sponsor for the series. And from Tata 1mg Labs, we also have our moderator today, who's Dr. Naveen Shivakumar, who's the pathologist and lab head at Tata 1mg Labs, Chennai. Before we start, a couple of quick announcements to make. Please post your questions in the chat box provided on your screen. The speaker will try to answer as many questions as possible in the limited time that we have. Also, you can download your certificate. In case there is any issue, try to refresh the screen and download the certificate through the link on your screen. We will bring up you more webinars on clinical topics next year also in 2023. To know more on these webinar series, do follow us on our social media handles, LinkedIn and Facebook at BMJ India. I would now like to introduce our today's expert speaker, Dr. Varinder Singh. Dr. Singh is the Director and Professor of Pediatrics at Lady Hardinge Medical College and Associated Kalavati Sarans Children's Hospital, New Delhi. He's also the chair of National Technical Expert Group on Pediatric TB for NTEP, Government of India. I welcome Dr. Singh to start with the session. Over to you, sir.
Thank you. So I am happy to participate in this educative activity. And in the next hour, which I have, I hope to take you through some of the common pediatric conditions which you will encounter in primary care. So how I've structured my talk is that wherever you are, when we say primary care, we mean simple illnesses which can be managed in the community or closer to community or at an individual clinic level. However, the health-seeking behavior of the community is very variable, and they may go to the nearest help post available to them without realizing the seriousness of the sickness many a times. So for a person who is working at the primary care level, it is very important to understand how to triage or do an emergency triaging to know who is at a risk of a serious illness or even death. So that will be the first part, where I will quickly take you through the emergency triaging, which will come handy to you if you are at a smaller health facility and occasionally get a sick child. Because if you're not a pediatrician, you may not be seeing as many children. And therefore, if you have an occasional sick child coming to you, you also take a little while to understand whether this child is sick or not. And that may be a little too late. Children and young infant, though all are children, but young infant, say between 7 days to 59 days, they are little more complex. And I'm not talking of newborns here at all, because it's impossible to cover that age group here. So identifying a sickness in them would require a little different strategy, which I would talk about. And then three common scenarios which we see: children with fever, children with loose stools, and children with cough. And take you through what is the recommended therapy, what is the recommended method of assessing these patients so that you are able to do a justice to them and treat them well. So with this background, let me start with the triaging. What do we mean by emergency triaging? You see, many deaths in facilities occur within 24 hours of admission. That means the children reach late to a hospital. So therefore, identifying seriously ill children closer to community or at the first health post or intermediate health post is very important. So they can be triaged and referred early. So the triage is a process of rapidly screening all sick children soon after their arrival in hospital in order to place them in one of the following categories. And those categories are emergency, priority, and queue. So if you have 5 or 10 patients waiting, how do you decide which one comes first? It can be uh, first come, first serve. But when illnesses are of varying sequences, seriousness, then this sequence may not work. So one may have to identify who are the children who are emergency or ease. So emergency children or emergency children demonstrating emergency signs are those who require immediate emergency treatment. If you find any emergency sign, you have to immediately start the treatment, call others well, draw samples, and stabilize this patient. Whereas those with priority signs are the ones who can wait after you are dealt with the emergency waiting in your area. And then are the queue, which are non-urgent. Where and who does the triaging? It can be carried as soon as a sick child arrives in a health facility, well before even any administrative procedure such as registration is done. It can even happen in the queue. And triaging should be quick. It is said that a trained individual, healthcare worker, can do it even in as short as a 20-second time and immediate triaging. And all medical and paramedical staff involved in patient care can perform triage if properly trained. Identification and classifying and further treatment requires a detailed training. So identification is easy. That can be done, task shifted even to your receptionist or a paramedic worker after any training. But treatment part is little complex, and that's where a medical personnel, trained paramedical person who has a detailed training would be required. Most children with emergency signs have physiological delays that may endanger their life. So that's something which is important to remember. Early recognition of sick children with emergency sign is vital to prevent mortality and morbidity. And children with emergency signs are most likely to survive if their emergency signs are picked up quickly and treatment started even before taking detailed history. The assessment of emergency sign is with an ABCD concept, where ABCD is A and B refers to airway breathing. So you see whether the child is breathing or not, whether the airway is obstructed. If the child is blue, does the child have severe respiratory distress? That means there is either a grunt or a severe intercostal recession or a respiratory rate which is more than 20 with the given cutoff for different age, which we'll be discussing little later. The C reflects upon the circulation. So circulation you can assess by seeing whether the child has warm hands. If not, whether the capillary refill time is longer than 3 seconds, which is done by pressing upon the skin or against, say, our sternum, and then you see how long does it that blank skin takes to come back to red. It should take less than 3. How do you count 3? You can say 1001, 1002, 1003, and that's 3 seconds. And whether the pulse is weak and fast. So to identify shock in young children, BP is often not used because you may not have the right side cough. You cough and you may BP cough for the monitor, and you may not even know which one to use. So these combination of these three, the child's hands are cold or peripheries are cold and CRT is more than 3 seconds and the pulses are weak and fast, are good enough to tell you that this child has a circulatory compromise and is in shock. And then we also quickly determine whether there is a problem with the consciousness or whether this child is convulsing. And finally, D is the dehydration. So consciousness can be determined and by whether the child is alert or responds to voice or responds only to pain or is totally unresponsive. The simple AVPU scale. And check if there is any active convulsion. And any child who has P or U or has an active convulsion, once you have controlled the convulsion, you will perhaps need to do further emergency treatment. In a younger child, remember the convulsion may be because of hypoglycemia, also sometimes because of hypocalcemia. So anticonvulsants alone would not be enough. A young child, small child or a child who has severe acute malnutrition. Remember, hypoglycemia may be the cause for the alteration in schizoid, in addition to many other metabolic causes. And the D refers to severity of diarrhea, dehydration, and which we are talking of diarrhea dehydration. So you assess severity of dehydration if the child has diarrhea. So that's the concept of ABCD in triaging. So once you have looked at air breathing and you have identified that there is not breathing obstructed breath, just give me a moment. Obstructed breathing, central cyanosis, or severe respiratory distress. If any of this is positive, then you have to manage the airway, give oxygen, make child is warm. If the child is not breathing or gasping, then you will have to start the life support. Before you manage the airway, remember you have to be sure that this child has had no fall or trauma, because you cannot move the neck if the cervical spine injury is possible. One of the things which we often forget while we are doing all this is that we forget that the child may be on a metallic surface or wet or with half his clothes taken off. This child can lose temperature very fast and become cold. Remember to keep these children warm while you are assessing or managing. In terms of circulation, as I said, cold hands, capillary refill, if any of this is positive or weak pulse, then look for the cause. Is there a bleeding? If there is a bleeding, stop it by pressure. Do not use a tourniquet because it can compromise circulation to the distal part. Give oxygen, make sure child is warm. The next step is dependent on whether this child has severe acute malnutrition or not, because the assessment of these signs in severe acute malnutrition is difficult, and the fluid therapy is little slow. So if there is no severe acute malnutrition, you can insert IV and give fluid immediately, but otherwise give slowly along with glucose for SAM, as I said, hypoglycemia. How do you know? If I said you can assess a child's within 20 seconds, and how do you know? As an identification of SAM can be done if you have weight for height, if the child has the document, which is less than CSD. Otherwise, you look for visible signs, and visible signs are visible severe wasting. Child is all bone, skin, no muscle mass. The gluteal fat or contour is lost, or presence of bilateral, fetal edema without a known cause like anemia or other things, severe anemia. And if the child has coma or convulsing, then you have to, in addition to managing the airway, give oxygen and correct hypoglycemia, calcium in children below 3 months, or give anticonvulsant like benzodiazepine, midazolam, lorazepam, which you can use to control the convulsion. The cases with severe dehydration, we will be learning how to assess the severity of dehydration a little later. Then again, if it is SAM, you give rapid fluid, and if it is no SAM, you give rapid fluid, and if there is associated severe acute malnutrition, you do not give IV fluids, you give ORS and immediately proceed to further assessment. Now, today's talk, I'm not going to speak much on SAM. All the children who have none of these signs which we have discussed till now are called priority children, and except provided they have these priority signs, and the priority signs being this being a small child less than 2 months, temperature being very high, trauma or urgent surgical condition, severe pallor, poisoning, pain, respiratory distress, restless, or he has been referred urgently from another health facility, severe malnutrition, and burns if major. All other classify as non-urgent. So this is how you would do a triaging for an older child. For a sick young infant, to know whether the child is sick enough to require a quick referral, is first thing is you ask whether the child has any difficulty in feeding. So remember, sick children often are disinterested in feeding. That is not same as difficulty in feeding. Difficulty in feeding is that child is just not getting onto the breast or bottle and is not sucking at all. If the child takes a few sucks and then refuses feed, is not difficulty in feeding unless until he's breathless. If the child has an active convulsion, uprolling of eyes, jitteriness, the clenching of fists, staring spells in a young child, think that this may be a convulsion. The next thing you do is you must count the breaths of this child. And remember, you have to count for 60 breaths for 60 seconds. And if the count is more than 60 breaths in 60 seconds, then you count once again, reconfirm it. And if it is there, then you have a problem. This child has a severe illness, possibly pneumonia, or sometimes it could be acidosis because of AKI or other things. You can also look for whether there's severe chest indrawing, which is the lower part of the chest going in. You measure the temperature, and if the temperature is high or very low, then you have a serious problem. You look for at the umbilicus whether there is red or draining pus. Look for skin pustules, and look at the young infant's movement. Often when we are jittery, we are said, "Are you a small child? Why are you moving so much?" So the same thing is for how do you know a young infant is normal or not? A normal young infant moves at most major joints several times in a minute. Either there will be a flicker of the eye, or there will be hand movement, or there will be a movement of the leg or movement of the toes, which you will see several times in a minute. If you do not see any such spontaneous movements unless until the child is in deep sleep, then possibly this is a child who's very dull and who's sick. And if the child does not move at all, there is a problem. If the child is sleeping, you can always check it with the mother. So from these signs, if child is not feeding well, or has convulsion, or has fast breathing, or severe chest indrawing, or has temperature instability, or moves only when stimulated, it's a very severe disease, and this is a child who should be referred to a facility for admission. Unlike an older child where you classify this as a pneumonia or a diarrhea, here you just look at the serious signs, and they often have cross-cutting illnesses or multiple illnesses at one point of time, and therefore cross-cutting diagnosis. And therefore, what we say is that these are severely ill child who needs an admission, and further investigations will establish whether there is septicemia, meningitis, pneumonia, or there is any other issue with that child. Sometimes they may just have a local infection, like skin pustules, which are small, no large boil, less than 10, or umbilicus, which is red or draining pus, but the surrounding skin is normal, which happens sometimes, where only an oral antibiotic or local antibiotic would be required in most situations. And child can be treated at home, and mother can be advised to watch this child for occurrence of any of the signs of severe disease. She obviously can't count the fast breathing, but if she thinks the breathing is abnormal, if you think the child is not feeding well, or has a convulsion, or is not maintaining temperature, they should immediately return back to you. If none of these are present, you can almost assure the family that there is no serious infection possible in this child. This algorithm would not cover for surgical emergency, like a severe vomiting, like a distended abdomen, which by itself is beyond. These are only limited to these 10 signs, which are largely about the common infections. The other thing which is serious in young infants is jaundice. And if jaundice appears within 24 hours of age, or it is at any time involving palm and soles, or continues beyond 15 days, then there is a serious problem. And therefore, this child should be referred, particularly if it is associated with clay-colored stool. So a young infant having clay-colored stool with jaundice is not a physiological jaundice. This is a child who has a serious illness, and if the jaundice is with clay-colored stool and beyond 14 days, we really have a problem at hand. If it is deep jaundice, if the hands are yellow and palms and soles, then also that is something which is a very severe jaundice, and they need to be referred. Otherwise, if the palms and soles are not, then solar therapy at home. But best would be, even in those situations where possible, send to labs, look at the bilirubins. There are charts, and see whether, according to the age of the child, they are beyond that cutoff or not. So if they are beyond the cutoff of 19, say beyond 5 days of age, of 13 at the age of 48 to 72 hours, depending on the weight, then you will have to decide whether you want to give phototherapy or not. If the child has diarrhea, then obviously you would also assess the dehydration, about which we'll be talking a little while. Third thing you always check in a child, newborn, is the feeding. You see, any new thing you get in, buy from or bring from anywhere, you get a complete module with it. what to do, what not to do. But no mother gets it with the baby. And with the families which are more one generation, there which where unitary families and just husband and wife, there is no one to counsel the mother what is right, what is wrong, how to feed, what is the right method of feeding. They hardly know. So assessment of the breastfeeding, if the child is not feeding on breast, not sucking effectively, has not taken about 8 breastfeeds in last 24 hours, and is not passing urine adequately, then you need to assess them. Often, first-time mothers particularly feel that they do not have adequate milk output. One of the ways you can know the milk output is adequate is if the child is gaining weight, or the other more simpler, if you may not have a reference weight of the past to say whether they've gained or not. In that case, you can ask whether this child is sleeping for 2, 3, 4 hours after having a take off nap between feeds, or if this child is able to pass frequently, urine is passed freely. So if this child is passing freely urine 4, 5 times in 24 hours, then that is adequate. Because if you are not giving anything else other than the mother's feed, that's where all that water is coming from. So that's a very good way of knowing the adequacy of feed, and then you can reassure. But if there are problems in attachment, problems in the nipples of the mother, or there are problems with the sucking of the baby, they need to be addressed particularly, as this can give rise to a lot of malnutrition later on. So you see, I am today only going to be able to give you a snapshot. For me to teach you each of these things exclusively, it requires an hour in itself. So you will only get a broad brush today. So we learned triaging, we learned assessment, importance of assessment of feeding. Quickly going on to the child with fever. When a child has fever, you obviously want to know the degree, type, whether it is with chills that may suggest malaria or bacteremia. But remember, even flu can give rise to chills. We saw that even with COVID. So even viral illnesses can give rise to chills. It's not always suggestive. One thing which we often say that it suggests that, which is a discriminator between bacterial versus viral illnesses, is what we call as a toxic loop. And that's something easily written than described. What we mean by a toxic loop is that this child is dull, is not playful, even when he is in comfort or at ease. So your fever has gone down. The child has no more has fever, but still is withdrawn and dull and not playful at all, not interested in the surroundings. Then this is a child who's sick, who's more likely to have bacteremia or any other serious illness. So that's something which is a very good distinctor for you to know how far this fever is bothersome. But inability to feed and not disinterest in feed is something else which tells you that this child is seriously, as we discussed a little while ago. Listlessness, playfulness is something else. A toddler who is after fever is gone, is not running around, is not well. You better be worried about that toddler. Same toddler, you are often worried कि अभी fever उतर गया, इसने दौड़ना भागना शुरू कर दिया. The child is running around, will again fall sick. You need not be worried about that toddler. Watch him, but you don't have to be worried. But if this toddler is not moving around, and even when the fever is down, then you have a serious issue at home, at hand, which needs to be assessed by a doctor. And a doctor has to keep in mind that it may be a serious bacteriological illness. General danger signs, which are kind of something even the lay community will identify, is lethargy, unconsciousness, or seizures. The child is non-responsive or totally vomiting out everything. And vomiting out everything is also something over-reported by the family. So if the child vomits 3, 4 times in a day, whatever was given has been vomited. You have to ask them, how many times did you feed? Did he vomit immediately? Did he vomit out everything? Did he retain something? Often you will find this. Kabhi-kabhi thoda pani to pee leta. More often when we will say that I have to admit and give IV, then they will open up and say, no, it's not that bad, doctor. He retained some feed, but some were not retained. I'm not saying you scare them with an IV line, but all I'm saying is that parents have not attended any such lectures, so they do not know what to emphasize and how much to emphasize, and whether those emphasis will lead to a diagnosis by the doctor. How relevant is to that history to us is not known to them. And it is always good to ask whether this child has a chronic illness, because that could be also be the cause of fever. So when you have child with fever, you would examine for to localize the cause for that fever. So if there is a stiff neck, there could be meningitis. A bulging anterior fontanelle could be meningitis. A red tender joint, septic arthritis, or sometimes rheumatic fever, which is not so common now. If a child with cough has fast breathing or chest drawing, then possibly you're dealing with pneumonia. A child with cough without fast breathing possibly has upper respiratory tract infection, which is usually viral, does not require antibiotic, while those who have fast breathing has possibly got pneumonia and therefore will require antibiotic in most situations. So there are also viral pneumonias. We recently saw that with COVID. And there are others. COVID is not the only viral bacteria. Influenza, parainfluenza, RSV are very common viruses which give rise to pneumonia. Presence of rash is something which sometimes gives us alternative diagnosis. Petechial rash, today recently we saw dengue with meningococcus. Vesicular or maculopapular rash may be because of viral infections. Measles, if it starts from the face and then goes to the body, it could be measles. Look at throat and mucous membranes. If you have an absolutely red tonsil with pus points and tender lymphadenopathy, then possibly you're dealing with a bacterial tonsillopharyngitis. Just bloodshot red face or mouth does not mean bacterial. High-grade fever does not mean bacterial. Absence of throat inflammation or a pus point in the tonsils. Tonsils can often have white plaques. Those are not pus points. Pus points are yellow. And absence of a tender lymphadenopathy cervical rules out a bacterial streptococcal pharyngitis. So here the negative value of absence of these signs is more. A child who's crying, a small child would often pull on his ear. That doesn't mean they always have an ear infection, but one has to look into the ear. And if it is an immobile eardrum, then possibly you're dealing with a otitis media, or a bulging eardrum, you're dealing with otitis media. An immobile withdrawn could be a serous otitis media. Look for jaundice or anemia along with fever. If fever finishes and then jaundice makes an appearance, then you know you are dealing with viral hepatitis. If fever continues with jaundice, then either it is a secondary infection, less common, or it's a complicated malaria, or it is a septicemia, or it could be a liver abscess. Look for bone involvement. Look for whether there is any tenderness in the abdomen, or in the renal areas, or in the right hypochondrium if it is liver abscess, or anywhere else. Appendicitis if it is the right iliac fossa. Some causes of persistent fever may not have any localizing signs, and that's could be sometimes very serious, like septicemia, salmonella, typhoid. May not have any localizing sign other than a small splenomegaly. Biliary tuberculosis, there may not be any chest signs. HIV, urinary infections, UTI in small children, spiking fever, chills, but no focus. So when children present with fever, they are largely in three categories: with localizing sign, without localizing sign, and with rash. And I sort of took you through the what could be the localizing signs which you could deal with. Without localizing sign, you could have malaria, you could have septicemia, you could have typhoid fever, you could have UTI, and that's something which will be proven by further investigations. And with the localizing sign, if you have stiff neck, bulging fontanelle, you know it is meningitis. If you have eardrum abnormalities or pus draining from ear, or older child complaining of ear pain, you are possibly detailing with an otitis media. There may be tenderness behind the ear, which is seen with the complicated otitis media like mastocytitis. You could have local tenderness in the bone or joint, which suggesting septic arthritis or osteomyelitis. There can often be fever with, boils or infected wounds, cellulitis, skin pustules, which is common in children, can give rise to fever. Sometimes can spread and give rise to metastatic abscesses elsewhere, which is pretty bad, and even pyomyositis. But most often it just stays restricted to skin. Superficial skin is strep, and deep skin is staph. So deep skins, you are more worried about there being metastatic abscesses elsewhere. So do a complete detailed examination if you have deep-seated boils more than one, or you have tender muscles or pyomyositis. Then there may be also associated empyema, pyopericardium, liver abscess, or abscesses elsewhere. A child with cough with fast breathing or with or without respiratory distress is more likely to have pneumonia. So these are the localizing features which will be able to tell you what you are dealing with. A child who does not have rapid breathing but has cough and has fever, and you look into the throat, there is just redness, you're dealing with an upper respiratory tract infection, which is more likely viral. You will also have more often symptoms of coryza, running nose, and you would have other mucous membrane involvement in under 5 children, like they may also have diarrhea, and you will also get a history of somebody in the family either recovering from an illness or also having a URI, and that's how it is commonly spread. But many children toddlers who go to day schools or daycare center will get it from their peers there. So you may not get a history from the household because they spend nearly 6 to 8 hours in that daycare center, and that's where they may catch their infection from. The third group of fever, which is very common in children, which one has to be aware of, is fever with rash. There are some terms which are used: exanthema and anthema. Exanthema is what is on the skin, and anthema is what is on the mucosal membranes. And within the exanthema, if it is a flat lesion, non-palpable, it is macule. If it is small palpable lesion, it is called papule. If it is large palpable lesion, it is called nodule. If that lesion becomes fluid-filled, then it is called vesicle. If it is large, it is called bullae. So onset of rash after a certain days of fever is kind of a fixed pattern. And this can be remembered by this mnemonic. If you are a mnemonic type person, it says very sick person must take double eggs. So what do we mean by that? V stands for varicella. Usually sign is often the first sign in these children. Rash is the first sign, and then you would also have fever. So it's fever and vesicles or rash. To begin with, the varicella rash may not be vesicular; it may be just a macular rash, then which evolves into a vesicle, is because of chickenpox. And remember, this can happen even in vaccinated children, though it would be mild. Second day is scarlet. Third day is smallpox, which we don't see anymore. And fourth day is measles. That's still with us. We recently had breakthrough infections reported from several major cities of the country, including Mumbai. So measles is something which comes on fourth day. It appears cephalocaudal. Remember, before you get a skin rash, you will get an enanthem called Koplik spot within with just opposite the second molar at the opening of the parotid gland. You will find. So it's an ulceration. Fifth day is typhus. This is something which is now coming up. You can see an scar more often than the macular eruption, which is seen with typhus. But with more and more people going out of towns as the towns are growing, and the barriers between villages and forestation and farmhouses or houses is merging, we are getting more exposed to ticks and therefore typhus. Dengue is again a macular rash, more seen on the distal part of the hands and feet, with a flushed hand on sixth day and entering on 7th day. This is typically a pleomorphic rash of chickenpox, where you would see a macular, vesicular, and a scab almost simultaneously. Unlike smallpox, where they were monomorphic. So if they were in vesicular state, all rashes were in vesicular state. That means they came in one crop, while chickenpox can come in several crops. The closest mimic of smallpox we have seen report, which is currently talked about, is the chickenpox, which behaves quite is the monkeypox, which is quite similar to the smallpox. Chickenpox is pleomorphic. Measles always starts with prodrome of fever, cough, coryza, conjunctivitis, unlike the chickenpox, where you sometimes notice rash as the first thing. Here, the child starts with URI-like symptoms with conjunctivitis. Then they have enanthem in the form of Koplik spot, which usually come by second and third day. And then by fourth day, you have eruptive rash. And even in measles, by the time you have rash within a day or so, the fever will just go away. Before that, it will peak and it will be spiking. If it does not disappear, then think of a complication. So if the child, and complications of measles are very common, like pneumonia, like otitis media. So measles is something which can really put a child really back, and therefore prevention with measles vaccine is something very important. Typically, rash is confluent erythematous macular and disappears in 4 or 5 days, and it leaves a brownie desquamation, which is something important to remember. So fever, localizing or no localizing. No localizing signs, either viral illnesses or malaria or typhoid, smaller children, even septicemia. With localization, it depends where it is localized to. Disease may be localized to either the respiratory symptom or to the gut or to the urine. If you have UTI, you may not really find all the time a history of dysuria or frequency, particularly in small children. They may only have fever. So the mean it falls in. This UTI is something which falls both with or without localizing sign, and younger children more often without localizing sign. In fact, you have high spiking fever, not getting coming down in a day or two. Look at the urine, and you may find it full of pus cells. And this happens more often now with the use of a lot of use of nappies, which are not changed frequently. And then you have eruptive. Two common things are chickenpox and measles. Rest I'm not going to teach you the whole of pediatrics. It's not possible to do that in 1 hour. So now I shift gear and take you to the next part of my talk, which is about dealing with a child with loose stools or acute diarrhea. I'm talking of a child who does not have severe acute malnutrition with acute watery diarrhea, because there the approach is you have to slowly build up the fluid, and approach is different. And today I'm not talking about that. I'm talking more of a child who's not malnourished. So diarrhea is something with where you have passage of 3 or more stools which are loose. So it's the character of stool, the change in consistency, which is more important than number. When it comes to younger infants, a young child who's breastfed, they will very often report uh, 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 loose stool. Mother will say the stool was not very well formed. That doesn't matter. In a young infant, you call it a loose stool if only there is hardly any fecal matter and there is only water, because they often have less formed stools, particularly when they are breastfed. So below 6 months, diarrhea is if you have more water than fecal. I would say not 6 but 3 months. So be very careful about that. Acute diarrhea is starts acutely and lasts for less than 14 days. Usually is watery, but can sometimes when there is visible blood mixed in the stool, it is dysentery. Distinction has to be made. Sometimes the mother say, "Oh, he has passed blood with stool." Every time you pass blood with stool is not dysentery. If you're passing blood with formed stool or constipated stool, there may be a fissure. The child may have a polyp. That's a different. That's a bleeding PR. That is not same as the dysentery, which is a visibly blood mixed in a loose, ill-formed stool with mucus. Persistent diarrhea, which is acute in onset and lasts for 14 days or more, is called persistent. The 6 key steps are: you treat dehydration with ORS, mostly oral rehydration therapy. Zinc is somewhat important adjunct therapy. Continue feeding or increase breastfeeding for a small child. Very appropriate restricted use of antibiotics only for dysentery, systemic infection, or cholera, single dose of minocycline or doxycycline. There is no role of any antidiarrheal drugs. So no antidiarrheal drugs, loperamide or whatever, should be used in children, or Caltain, nothing. And advise the mothers to increase the fluids or feeding during future episodes. So your steps of treatment would be assessing and classifying degree of dehydration and planning treatment. So look at, confirm the child has diarrhea, ask whether there is blood, very important thing is whether the child has passed urine or not, because they may be going to renal failure because of dehydration. How many are the episodes of vomiting? If this vomiting is bilious, think of a surgical cause. That's something important to remember. Whether there is other sign to suggest that there may be a serious illness like convulsion, then this child cannot be treated at home. And look at the feeding practices. Those who are bottle fed with poor feeding practice were more likely to have bacterial infections. Otherwise, most of pediatric diarrheas are viral and do not require antibiotics. What drugs they have taken, etc. The emergency signs, as was already discussed, ABC are done, and then in the dehydration, you look for assess the severity of dehydration. So look for general condition. If you see a child is lethargic, not mobile, or restless or irritable or normal, the first two signs may be seen with lethargic or unconscious. If it is because of dehydration, would be severe dehydration. Remember, lethargy or unconsciousness could be reflecting some other sinister disease also. The differentiation is if you, when you rehydrate these children, if the unconsciousness or lethargy comes back, recovers immediately after rehydration, the sole cause was dehydration, severe dehydration. Otherwise, there is an underlying other illness which is causing. If the child is restless and irritable, thirsty, then there is a moderate, mild to moderate deficiency. And if he's alert and looking into your eyes with gleaming cornea, no drying of skin or turgor, this is a normal child. Look for sunken eyes. You can see from the side that the eyeball looks gone back into the socket. Often it helps to ask the mothers if they've gone in. This is something which is relatively subjective, but a very good tool. And then is to look at skin pinch. You pinch the skin, locate the area on child's abdomen halfway between the umbilicus and the side of the abdomen. Hold it not between the tip of your thumb or finger. Hold it between the digits with your hand and pinch the score for 1 second and then release it. If you are able to see it tinting like this, that means it's going back very slowly. If you are just able to see it going back, then it is slowly. So very slowly is when it takes about 2 seconds or more. If you can't see it going, it is immediate. Immediate is normal. Slowly is a trouble, and very slowly is also a sinister sign. And then you can assess the thirst by offering fluid to the child. Because many of these signs singularly may over pick up dehydration, we always use them in combination. So if you have lethargy with sunken eyes, or not able to drink, or drinking poorly, or skin back, pinch back goes very slowly. If it out of these four, you have any two signs, then you have severe dehydration. If you have one sign, then you don't have severe dehydration. If you have one in severe, one in some, then you have some dehydration. So every box, you have to have at least two signs to call it some dehydration. If you have, so it is going from above downwards in the degree of severity. So if I do not have two signs in first, I do not have severe, the patient doesn't have severe dehydration. If I don't have two signs in second yellow box, then I do not have some dehydration. Even if I have one sign, I have no dehydration. So for some dehydration, restlessness, sunken eyes, drinking eagerly or thirsty, and skin pinch back goes slowly and not very slowly. So very slowly was more than 2 seconds. So that's how you simply assess dehydration with simple tools, and it's a very, very, very good tool used even in as advanced centers like ours. It is not that it is only for periphery, and it's a very good tool to assess dehydration. And depending on the dehydration, you have a plan to how much fluid is to be given. Dehydration severe is plan C, B, and A. I will discuss that. So when children have severe dehydration, then you have to give 100 ml per kg of intravenous fluid immediately, because this is a child who is going to a circulatory compromise. The rapidity with which you will give fluid will depend on whether this child is below 1 year or above 1 year. If this child is below 1 year, you give 30 ml per kg in first hour and then rest in the next 5 hours. You are rehydrating over 6 hours, while an older child you would rehydrate fast in about 3 hours, 30 minutes, and 2.5 hours. Also, keep on giving orally if the child is not vomiting, because that will improve their hydration faster without any risk of a fluid overload or anything, because it's orally. The child will accept orally if only the child is thirsty and is able to take. Now, it is also important that once the rehydration is completed, that you keep this child under watch, because this is a child who was seriously ill before you discharge them or send them. And this is a child or any child, we also have to look at the ongoing losses about which I will talk a little later. If the child did not have severe dehydration but had some dehydration, so then we give 75 ml. So 100 ml in severe, 75 ml in some dehydration, but 75 ml per kg. Now you're using ORS. In severe dehydration, it was intravenous fluid of ringer lactate. If not possible, child taking orally, while child is going to the hospital, keep on giving ORS to a plan C patient also. But that's not the best way of therapy. Best way of therapy is to start intravenous, or if not possible by OG, or give orally as far as possible while you are shifting the patient. While plan B is within the health facility and you give 75 ml per kg, and if the child wants more, you give them more. After 4 hours, you reassess and classify degree of dehydration again. If there is, once you have to tell the mother how to prepare. If the child vomits, ask them to wait for 10 minutes before you give them more ORS solution. It is so the important thing to remember is in plan C, when you have no dehydration, you're sending them home. You give them extra fluid, ORS, oral zinc. All of these three categories will get oral zinc. I'll talk about the dose little later. You continue feeding and when to return is the advice you give. You also need to give extra fluids to meet the ongoing losses. So suitable are ORS or salted rice water, salted yogurt, matcha as it is called, vegetable soup, chicken soup with salt. Unsalted fluids which may be suitable are which have natural salt in them, like green coconut or cereal, which tastes like unsalted rice water, or unsweetened fresh fruit juice, canned juice. The mothers can also prepare solution if they do not have ORS at home by mixing up 3 grams per liter of table salt and 18 grams of common sugar. It is as good, but is usually not recommended because they forget, and if they use wrong proportions of salt or sugar, you will have a problem at hand. And now ORS is very easily available, but if required, it can be made at home. What should not be given is any of the cokes or carbonated beverages, fruit juices, or sweetened fruit juices particularly, or glucoses, or energy drinks, or sweetened tea, coffee. These are a no. What we currently recommend is a low osmolality ORS, which contains 75 milligram. Earlier we had 90. These are easily available in the market. What you have to remember is, in the market you get 2 pouches. One pouch which is for 200 ml of water, another for 1 liter. If the parents use this salt meant for 1 liter in 200, then you will have hypernatremia. Or if they use 200 milliliter salt in 1 liter, you will have a diluted or hyponatremia. So remember that the mothers are educated about the type of ORS packet they are getting from whichever source, public or private, or from the market, to see whether it is to be mixed in 1 glass of water or 200 ml, or 5 glasses, which is 1 liter. The low osmolality ORS is now preferred, which is 75, because it decreases gastric emptying and prevents vomiting, and decreases the unscheduled requirement of IV fluids, and therefore is useful. Once the mother is the rehydration is done, then it is important to tell the mother to frequently breastfeed the child and give exclusive breastfeed with ORS. If exclusive breastfeed, then you can even give only ORS. Otherwise, you can give other suitable fluids. What is important is to remember we give about 50 ml to 100 ml for each loose stool below 2 years, and above 2 years, because the volume may be more, you give about 100 to 200 ml. It is always a good idea to look at what amount of stool is being passed. Sometimes ORS will not be useful. Then you have to go for ORI, for IV fluid, even in some dehydration, like high stool purge rate, more than 10 loose stools per day, which are large volume, persistent vomiting, or abdominal distension or itis. Zinc is something which helps rehabilitation of or rejuvenation of the gut, and 20 milligram per day for 14 days. It's not till you have diarrhea, you have to give for 2 weeks, because you want to replenish that in the brush border, in the epithelial lining of the gut. In children between 2 months to 6 months of age, it is half of it, 10 milligram. We do not give it to children below 2 months of age. It can be divided into two doses or given as a singular dose. Most of the syrups which come in market are contain 20 milligram per 5 ml. There are also tablets available. Continue feeding, because appropriate feeding will decrease stool output, shorten the duration, and improve the nutritional status. And that's something which is very important. Feed an extra meal to recover during convalescence. Give energy dense feed. Give extra amount so that child is able to regain weight and for whatever losses he had. Tell the mother to come back if the child is not drinking adequately or is not able to drink, looks lethargic, develops a fever or blood in stool, or has not passed through the urine for more than 6 hours. These are the times you cannot give home therapy. This is a child who requires further intervention. Finally, coming to the last part of my talk, which is on child with fever and cough with difficult breathing. They're a very common problem in young children. Usually are mild, self-limited. Pneumonia is the single largest infectious cause of death, and that's serious. That's not mild. That's not self-limited. Which children with respiratory illness are seriously ill? Those obviously not breathing, obstructed central sinuses. If the oxygen saturation is going below 90% in room air or not maintained uh, even now with the 60% FiO2, this is a respiratory failure, sign of severe respiratory distress, which is if you are cut off, you are 20 breaths more than the cutoff, or more than 78 an age, or you have grunt, or you have coma, you have convulsion, or inability to feed your interval. So we ask the usual question: duration, associated features like fever, whether there is noisy breathing. Grunting is a breathing against closed glottis. This is grunting. And if you hear grunting, this suggests that this child is seriously ill and has a pancreatitis. Stridor is suggesting upper airway obstruction. So this will be an inspiratory sound, like this. And wheezing is an expiratory sound, which suggests a bronchospasm. So these noises are important, and which can help us know what kind of disease you are dealing with. Difficulty in breathing, chest pains are other. If there is sudden choking, that this child may be having foreign body. History of measles, there could be bronchopneumonia or sometimes even tuberculosis. So one has to look at whether there is exposure to TB or possible HIV infection also need to be asked about. Respiratory rate is something which is very useful. Count for full 1 minute, particularly in young children. And when the baby is calm, keep the wristwatch next to the point where you are looking at the breath and not on your hand, so that when you glance away to look at the hand of the clock, you are not missing few breaths. It happens. The other signs which are useful may be excessive irritability, suprasternal recession, we already talked of noising, and head nodding, which is a movement of the head synchronous with inspiration. So this is how suprasternal intercostal recessions of sinuses look. You may also have a child who has throat congestion or severe pallor or lymph. Respiratory system, you have to auscultate and look for whether there are unequal entry, crackles, wheeze, or signs of stony dullness, percussion suggesting pleural effusion. Cardiovascular, whether there's any shift of mediastinum, which may happen with either a pneumothorax or effusion. Abdominal examination, there may be a push down liver or spleen, or there may be an enlarged liver, which may be because of a CHF. So once you have a child with cough and difficulty, then you look for presence of general danger sign. If the general danger sign, you immediately do an emergency treatment. If it is COVID season, then we send the COVID swabs. Today we are in relatively soft times which are quieter. China is currently having a big epidemic. If there's nothing, no emergency sign, no sign to suggest that COVID and child is otherwise fine, there is no difficulty in breathing, then you go further and see and assess this child for these things. Whether there is a wheeze present or whether there is a stridor present. If there is no wheeze, no stridor, then this is more likely where this is the commonest thing which you'll be seeing. So then you count the fast breathing. Fast breathing means more than 60 breaths per minute in a child less than 2 months, more than 50 in 2 months to 12 months, and more than 40 in 1 year to 1 year to 5 years. So if you have fast breathing or chest indrawing, then you know it is pneumonia. Classify severity and treat, which we'll be talking about. But if you're fast breathing with other systemic examination being abnormal, like you have meningitis, so it could be central breathing, or you have fast breathing without any significant chest indrawing and chest signs, no auscultation, no crackles, then possibly this could even be an acidotic breathing. So no fast breathing, no chest indrawing, then it is which will be your commonest situation, which is an upper respiratory tract infection, and which is viral most situation. If wheeze is present, then it is a wheezy disorder. Could be first timer, could be bronchiolitis, pneumonia with wheeze, recurrent could be asthma or stridor, as which I showed you. Demonstrated to you the sound, which is an inspiratory hard sound. Could be because of viral illness like crude laryngotracheobronchitis, or because of diphtheria, or sometimes because of a foreign body in the large airway. So if you have any signs of severe respiratory distress, general danger sign, or cyanosis, which we had discussed, or oxygen saturation less than 90%, severe pneumonia, these children should be admitted and given oxygen in addition to the antibiotics and resistance. If there is none of these, but there is fast breathing, then you need oral antibiotics. Amoxicillin is good enough for most. No need for amoxiclav, because the commonest bug is pneumococcus. It does not produce beta lactamase. Comoxiclav is your second line drug. Should this a child below 2 years can have H flu, and H flu can be a beta lactamase producer and may be resistant to amoxicillin, then you may need it. So severely ill, not responding, there may be a place for amoxiclav. You're thinking of a complicated pneumonia, you want to cover for staph, there may be a place for amoxiclav, which is a very commonly used antibiotic, but not required. What you need is only amoxicillin, oral amoxicillin for 5 days. In an old admitted child, you may use instead injection ampicillin with or without gentamicin. This is child who's malnourished, or an infant below 6 months. You may like to add gentamicin, because there is gram-negative bugs are also possible. And if there is no pneumonia, no antibiotic, until it is an acute streptococcal pharyngitis, which I have already told you. 3 things to look at: redness, purulent discharge in the tonsil, and tender lymphadenopathy. If you do not see that, you do not have, these are more likely to be viral. One bacterial illness which may not give very high grade fever and may not have these signs is diphtheria. Then you have a swollen bull neck. You will see a membrane, which is typically seen. So this is also a disease which is coming back when in the poorer populace, the vaccination rates have gone down. Just as we are seeing measles, we are also seeing diphtheria in some parts of the country. A sick child, you have to give oxygen, IV fluids, get a chest X-ray, treat with IV ampicillin, treat wheeze if it is present, monitor every 3 hours, if reassess it 48 hours. If there is no improvement, you may have to upgrade or look for other causes. You may upgrade to a third generation cephalosporin with gentamicin, or you may upgrade to a comoxiclav. And this is if you think there is staph, comoxiclav or cloxacillin is preferred, and staph is suspected when there is presence of pleural effusion or a boils or pustules in the skin of the child, where from they may have traveled, or if you also have associated empyema or pneumothorax. Supportive care is antipyretics, intravenous fluids, bronchodilators if there is wheezing. Monitor every 3 hours and look for signs of improvement. No improvement 48 hours, then look for complications and alternative teaching. Complications are pleural effusion, air leak, septicemia, septic shock, or secondary metastatic infections like meningitis, arthritis. The final thing is that there could be children who have, I'll skip this slide, who have wheezing. So once you have this child who has wheezing, ask whether this has happened in the past too. If it has happened in the past, then possibly you're dealing with a virus-associated wheeze. The children usually less than 3 years with recurrent episodes, typically starts with an URI and no family history. Same child with a family history or has symptoms in between, it could be a preschool asthma or multi-trigger wheeze. It is a first episode. There is a preceding upper respiratory illness, rhinorrhea, nasal discharge, hyperinflation of the chest, fine crackles with or without wheeze, then possibly you're dealing with bronchiolitis. Or if there is none of these qualifying features, then pneumonia can also give rise to wheeze sometimes. So that's how, if it is not pneumonia with wheeze, all other 3 do not require antibiotics, they require bronchodilators. So remember, This distinction is also very important, though both of them would have tachypnea with cough. So cough with tachypnea is not always equal to having pneumonia. So this is something which is important to remember. So if V's is present, then you can either give 3 doses of nebulized salbutamol, or you can even use MDI, look for response. If the response is there, you may continue same. So finally, to conclude, children are not miniature adults. They have specific illnesses with their each one of it having its own management protocol. Triaging of children is a very important tool which should be learned by all frontline workers and first responder doctors. Newborns often have subtle signs of sickness, and therefore you may not be able to clearly say whether it is pneumonia or whatever or meningitis till you have investigated further, and that is why we often call them a sick newborn further investigations. Older children, it is possible to qualify fever. They would require investigations just like newborn, but not always. If you have no localizing signs or you have just URI, and possibly viral in the viral season, but if it is coming with chills and rigors, alternate, it could be malaria in a malaria season. If it is continuing, persisting step ladder pattern, it could be typhoid. If it is a small child who may demonstrate some urinary symptoms or is using a lot of nappies and pads, stuck, it could be a UTI. If there are signs of involvement of a particular system, then that's the localizing sign. If there is rash, and I've taught you of the common illnesses which come with rash, and on the day of illnesses they come. First day is chickenpox, second day scarlet fever, third day monkeypox or smallpox, which are not chikungunya, fourth day measles, and like that. Diarrhea, dehydration management is most important. ORS can work in most situations, but when severely ill, 100 ml per kg is required. 3 to 6 hours is time over which you give it. And drinker's lactate, that's what you give. Moderate dehydration, 75 milligram per kg, low osmolality ORS. Zinc is the most important drug this child needs, not an antibiotic. Antibiotic required if there is blood in stools, dysentery, or cholera. Pneumonia management requires antibiotic. Cough does not require antibiotic. Coughs are not equal to pneumonia. One question I'm sure you're going to ask is, which is the best cough syrup? Cough syrup is a typical example of confusion because it's a confusion of there being a expectorant, there being a cough sedative, there being an antihistaminic which dries out secretions, and you don't know what is going to work. So you can't sort out confusion in our head of what to give with the confusion of another kind called cough mixtures. Cough mixtures are largely avoided, not required. You may require symptomatic therapy for URI. Sometimes there are bothersome symptoms where first generation antihistaminics are good enough. So thank you very much for your time and patience, and I'm ready to take any questions. Should I stop sharing my slides? Okay.
So thanks a lot, Dr. Singh, for the wonderful presentation. I have a few questions in the link. I'll be asking from them.
Yeah.
Let me start with the first question. The first question is from Maruti AR from Chennai. The question is, when should one investigate acute febrile illness in a child?
Oh, well, there is no given time frame when you investigate. It depends on the severity, or it depends on your differential diagnosis. Now, someone who has come with in a typical viral season, when you are community, you're seeing a lot of viral and does not have any dangerous danger sign, you may choose not to investigate and only give antibiotics, or at the best may do a CBC, though that is also not going to be very helpful. However, if you are, this is not following a typical pattern of by day 2, 3, it is going down. And then this is a child who may not have viral illness, and therefore you need to investigate. Same child on day 1 is sick, or you have any localizing feature. Depending on what localizing feature you have may require further investigation. Now, if a child has rapid breathing and cough, does he actually require any investigation? To my mind, no. Because you're going to give antibiotics. Whether there is anything in the X-ray or not in the X-ray, you're going to give antibiotics. Whether the counts are normal or abnormal, you're going to give antibiotics. Then there may not be a role of going upfront with an investigation in that case. Yes, in an ideal situation, you would need a CBC, maybe a qualitative CRP, and an X-ray. But if you're using all these tools, then you should also have the courage to use antibiotics if only you get an evidence of bacterial infection. I do realize all of these are not that robust. So if the investigations are to be done if they are going to add value to your prescription. If they're going to have a discrimination in your prescription, go ahead, do it. So it's not a matter of time frame. It depends on the severity, it depends on the presentation, and it depends on the context.
Thanks, Dr. Singh. To add on to the question, there has been cases of CRP being used as a criteria for admission. In your opinion, would it be wise?
No. One line, no. CRP is a marker of inflammation, not of infection, and not of bacterial infection alone. It is raised in bacterial infection. And there is no level of CRP which decides that you're sick. It is your sickness which is visible to you in the assessment of the child, which decides whether the child needs an admission or not. So merely triggering based on a number of CRP, none of the textbooks say it. So I would not recommend. And I don't do it in my practice.
Thanks, Dr. Singh. Is there a difference between asking for urine routine and urine culture in infants and child when you assess for UTI?
You see, urine culture is often required when you do not have a localizing feature, because initial time you may not get enough pyuria. But if you have pyuria and you have urinary esterase, leukocyte esterase positive or nitrates positive, you're dealing with an infective situation. That's good enough. But culture would be required in that case as a second step, because that could have happened with a routine sample. But for culture, you have to have a clear catch sample or a catheterized sample to make any meaning of whatever gets cultured, whatever isolate is grown, or whether it is in adequate numbers or not, whether that's a causative organism or not, and to know the sensitivity. So culture is important. However, it's only in young children where it's too early, then one may go straight away also for culture. Otherwise, we first do a routine examination. Depending on the clues, we decide about culture.
Thanks, Dr. Singh. Next question is from Dr. Jafrin Firdaus from Dhaka. His question is, can we call it dysentery if there is not visible blood in stool, but the child has fever, abdominal cramp, and stool in mucus mixed?
Well, typically dysentery means you have to demonstrate blood. So in early stages, it is possible what you are describing is possible. That may happen. And when you will do microscopy, you will find RBCs in those situations too. But remember, this clinical setting which you are suggesting is possible even without dysentery. So that therefore would be less sensitive, though it is possible to have, these features are possible with dysentery. It will not be that specific in the absence of blood.
Thanks, Dr. Singh. Next question is from Suryanath from Anuradhapura. The question is, how is post-viral cough managed at GP setting?
Post-viral cough, one has to investigate. If it is gradually decreasing, you need not do anything, or maybe use some home remedies, like anything to soothe the throat. There's so many home remedies which are honey or lemon or ginger or whatever. However, if it is bothersome, if it is more at night, early morning, or a child who has a feature of atopy, earlier had eczema, or has a family history of atopy, then this could be a marker of post-viral reactive cough or asthma, which requires a definitive therapy, not with antibiotics, but with anti-asthma medications and bronchodilators. So it depends. One has to really see. A lot of time, by the time you are into week 2 or 3, usually by week 2, the most viral coughs will go down. If they are continuing thereafter, then one needs to make this distinction. If there is sometimes even in the absence of a history of atopy, personal or family, they may have increased hyperreactivity and they may benefit with the same drugs as we are used for asthma. But it cannot be a blanket treatment again. It depends on the severity or persistence. The second thing which is also to be kept in a post-viral cough is that if this cough is wet and there is associated low-grade fever or nasal discharge, which has come the second time, think of a sinusitis. So secondary infection in a viral sinusitis may have a bimodal peak, and then you second time you get fever again later on, and that's where the chronic sinusitis will come out. Then you need antibiotics. So again, when we say the cough has continued after an initial viral illness, one has to look at the other context and other parameters to decide where this will fall.
Noted, Dr. Singh. The next question is from Najhat Sara from Chennai. The question is, can you explain about the management of allergic rhinitis in children?
Well, allergic rhinitis is treated if it is persistent and severe, and there are grading about that, how frequent, how much it affects the child's activity of daily living or studying or disrupts the sleep, and how many days in a week and how many weeks in a year. Then you decide to treat them. If it is mild and intermittent episodic, then you use oral antihistaminics. You can use non-sedating antihistaminics for that. And if you are someone who has a persistent chronic, in that case, you need intranasal antihistaminics or intranasal steroids. That's a different ballgame altogether. So allergic rhinitis, that's the broad view I could give you, that it depends on the severity. Not every child needs a long-term therapy, and depending on severity, there is a graded drug use, which I have explained.
Thanks, Dr. Singh. Next question is from Aparna Pandey from Raipur. Are there any recent developments in management of seizures?
Seizures. Well, there are some new drugs which have come up. Beyond that, I don't know what do you mean, because we may be talking at cross purposes, whether we're talking of acute management of an active seizure or we're talking of a long-term management of epilepsy. Both have seen some changes, but suffices to add that most of the earlier drugs are still used as much and are useful. So there's nothing which has totally changed the scenario, but there are changes.
I'll go the last question. That is from Dr. Shaukat Ahmad Pare from Badgaon. Is there a drug of choice in tinea corporis, and what is the dosage in children?
Sorry, I would not know the right answer to it. We were earlier using griseofulvin, but we usually seek help of our colleagues in dermatology. I do not treat this, so if there is something new, I would not know. So I will refuse to answer this question.
So that's it from my side, Dr. Singh. Thanks a lot for your patience in answering the questions. Over to Sheetal.
Yeah, thank you. Thank you, everyone. Thank you, Dr. Singh and Dr. Naveen, for such an engaging and interesting session. And thank you to all the delegates who attended today's session. We hope we've been able to meet your learning expectations. And so this being the last session of 2022, we thought that we'll quickly give you an overview of what was being delivered under this program so far. So those of you who've attended this session for the first time, we started this initiative in January 2022. And under this initiative, we've delivered 12 webinars, 12 different webinars so far. Each session was attended by more than 500 healthcare practitioners across India. And on an average, 35 to 45 questions were answered. These were very interactive sessions. Post-webinars, our attendees have received Tata 1mg Labs coupons and also certificate of participation. And we've got more than 550 positive feedbacks on these webinars. Just to give you an overview, we've covered therapies like cardiology, respiratory, diabetes, psychiatry, infectious diseases, rheumatology, neurology, dermatology, neuro, and women's health, and also pediatrics today. So we've covered 12 different therapy areas in this past 1 year, and these were delivered by some of the most eminent speakers in India. They are academicians from prestigious institutions and hospitals from AIMS, CMC Vellore, ICMR, as you can see there on the list that is displayed here. If you wish to view any of our past webinars under this program, they are all archived on our YouTube channel, that is Education from BMJ. you can have a look at this channel and you can go through the past webinars. In the end, I request you all to fill up the feedback form. It takes only 30 seconds, but it helps us to bring to you better programs, better initiatives. And with this, we formally close this session now. I wish you all Merry Christmas and Happy New Year in advance. Thank you so much. Thank you to our faculty.
Thank you, Sheetal. Thank you, everyone, and Happy New Year and Merry Christmas to everyone. Thank you.
Thank you.
Thank you, everyone.